Hi everyone, today we're going to present a project using a machine learning algorithm to predict the cost of subcutaneous tissue debridement across the United States. And this is done as a case model to test our pipeline to predict medical costs. We're going to introduce the topic, our motivation behind this, some of our methods, our results, some limitations, our conclusions, and future directions. So we're motivated because healthcare spending in the United States is highest in the world. In 2023, we spent approximately $4.9 trillion, which averaged to over $14,000 per person annually, which is far exceeding any other developed nation. But patients still face unpredictable and unaffordable costs due to very opaque pricing and a lot of surprising out-of-network bills. And so even though there have been policy measures like the No Surprises Act of 2022 and the Hospital Price Transparency Rules of 2021, which aimed at improving cost predictability, a lot of challenges remain in how these are enforced and how these are interpreted by consumers. So the unpredictability in prices undermine patient trust, and it leads a lot of people to delay or forgo crucial medical care, which highlights the urgent need for accurate tools to predict medical costs. We're focused on subcutaneous tissue debridement because there's a very niche procedure that has very significant price variability. It makes it an ideal case study for cost prediction. So in this project, we aim at developing a machine learning pipeline that accurately predicts costs using comprehensive data sets. And we focused on payer, location, and the procedural metadata. Our goals in this project more broadly are to improve the price transparency and create a tool that can help patients and providers in providing cost estimates and cost planning, and also uncover regional and insurer-specific pricing dynamics that are unknown. Our data set comes from hospital data across the United States, and this is as a result of recent laws that mandated hospitals to produce their data into how different procedures are priced. And so our CPT/HCPCS table includes the specific medical costs, sorry, the specific medical codes that are used for billing. The hospital tables include hospital metadata, including the name of the hospital, the location of the hospital, and other contextual information. And then lastly, our pricing table, which captures the core pricing data for medical procedures like hospital and other procedures.
So we start off by also cleaning the data prices and hospital. Uh, Price data set contains over 4 million records of prices with extreme outliers. And hospital data set has missing values in some of the columns. So we start off by deleting those columns that have missing values like street address, city, the hospital names. And also from the prices, we remove the zip code and publish date to reduce the noise and redundancy. For states in the hospital dataset, we don't want to look at all the 50 states, so we reduce to only top 3 most frequent states, which are Michigan, Florida, and Texas. After cleaning both hospital and price datasets, we merge those two datasets using the NPI number, which is the common feature for both datasets, and also grouped the low frequency payers into other category and kept the rest of top 9 most frequent payers as they are. To look at the distribution of prices, we plotted the box plot that you can see on the left side. We see that this plot has a lot of outliers for prices higher than 10,000, and that's how we are not able to see the actual box. So we decided to trim the prices which are more than $10,000, as we see in figure 2, box plot 2, which shows that most of the prices are spanning from $0 to 1,700, and the median is around $700. So most of the prices beyond 4,000 are mostly outliers. And that's why in the next slide, we are going to trim further and focus on the prices below 6,000. So in this histogram, we show the prices which are less than 6,000, and we can see that most of the bars are located on the left side. So most of the data is between 0 and like 2,000. So after cleaning and trimming prices and hospital, now we are merging it with CPT HCPCS, which contains the procedures. So we combine these two datasets by procedure code because it's common to both datasets. And originally, these two datasets have a lot of rows and columns that are not necessary. So that's why we are going to trim further and also remove some unnecessary columns. Um, in CPT, we have short description which describes the procedure, but code is already describing each unique medical procedure. So we remove state column because it's not necessary, and also categorize the payer further because originally we had kept 10 categories for the payer. So here we decided to just focus on the top 5 payer categories for our data set. And for the hospital, we decided to focus on just one procedure, which is HC, removal of damaged skin and underlying tissue. We chose this because it's among the most frequent procedures. And also, this is a common procedure that is seen across most of the hospitals in the US. So now that we have cleaned the data, we are ready to do transformation of the data to train it on the machine learning model. So we start off by standardizing the data using standard scalar that allows the data to have the mean of 0 and standard deviation of 1, which makes it easier to train the models with less biasness. And again, we transformed the price from original price dollars to the log scale. And you can see that we use the log 1 plus x instead of log x because we have prices that are equal to 0. So to avoid errors when the value is 0, we just chose to use log 1 plus x. And in the next slide, we can see the importance of transforming the price from original to log scale. When the price are kept in the original values, it's right skewed, where we have a lot of high values here on the right side, and the mean is higher than the median, which will lead to biasness if we continue training on this type of data. But by looking at the log transformed prices, we can see that now the shape is bell shape, which is standardized and also has balanced the data to make mean and median be in the same location. Some of the evaluation metrics we are going to use is MAE, which is mean absolute error, which is computed by taking the actual value minus the predicted value and do the average of that. So the absolute value to eliminate any negative values. We also do mean squared error, which is the square of mean absolute error. This is used while training models to minimize the loss function. So we want to minimize errors to as low as 0. We also used coefficient of determination, which is R squared. And this one, we want to make sure that it's close to 0. It's close to 1 so that we are taking care of the entire data set and all the variations in the data set.
All right. Because we chose to do a regression task, we chose these three models because we've thought that these models will be able to accomplish the task that we want. So first we chose linear regression because this is the simplest and the most easiest model that we can start with, because first it only captures linearity, and from there you can learn from what is the baseline trend, and then you can improve from that. And then our second model is decision trees, because compared to linear regression, decision trees can actually capture nonlinearity. And also it's more intuitive to understand because you can see like the decision tree split up as it's going down, as it's increasing in depth. And this is usually much more easier to understand and analyze. And then our last model that we used was neural networks, but specifically feed-forward neural networks, because neural networks usually help to capture very complex nonlinear patterns. So for the complex nonlinear patterns that wouldn't be able to be captured using linear regression or decision trees, FNN would do a better job to not only just capture that, but also like balance predictive power and also just like generalize across the entire data set. So the two graphs that you see are the linear regression plot lines for actual versus predicted prices. And as you can see on figure 1, this is our linear regression based off of real prices. And as you can see, it's not really capturing well the data set, right? You can see a lot of outliers. You can see it only capturing a few data points. And you can look at the top right results and see that linear regression actually performs better when the prices are log transformed than when the prices are real. This makes sense because obviously linear regression is really dependent on how the distribution of the data set is. And once you do log transformation, as was mentioned by the previous speaker, this helps linear regression perform better. And then on the slide, on the figure on the right, which is the quadratic regression, you can see that it performs much better than linear regression. And you can see that it's able to capture the actual prices, especially the low actual prices, with a few outliers, especially for the higher prices. And you can also see the metrics that they are way better compared to the metrics before. So after performing linear regression, we went to decision trees because obviously this helps capture the nonlinearity of the data set. And we used the decision tree to we first set the maximum depth to 6 because obviously I think this is a perfect number to balance between accuracy and overfitting. We also made sure that this was entirely random, so we fixed it at 42 for reproducibility. And also we set our criterion was squared error so that we can reduce variance, especially when the tree is splitting. And some of the metrics that we were able to gather from the decision tree were first, it performed much better compared to linear regression, especially on the real actual prices. And this makes sense because decision trees usually capture the nonlinearity of the data set, right? And they're usually not prone to how skewed the distribution, how skewed the data set is, how skewed the distribution of the data set is. So decision trees really performed well. So as you can see, the mean squared error was very low and the mean absolute error was also very low. And the model also kind of showed clear signs of overfitting and sometimes memorizing training data patterns. So this is the decision tree diagram that we used. And as you can see, the maximum depth was set at 6. And you can see the decision tree split up as it starts from the uppermost node towards the leaves at the bottom. And then lastly, we finished with feed-forward neural networks. Specifically, the activation function that we chose to use was called ReLU, Rectified Linear Unit. And the formula for this is also displayed there, which is maximum of 0 and x. So if you have ReLU of 5, then the answer is 5. If you have ReLU of a negative number, then the answer is 0. And this obviously helps avoid getting negative values. And we also noticed that this model also performed very, very well, especially on log prices. As you can see on the metrics on the right, our R squared was 0.691, our mean squared error was also very small, and our mean absolute error was also very small. So what is the physical significance of the metrics that we had, right? Like what do they mean physically? So looking at the graph, you can see the average procedure costs by state and pair group, right? So you can see Michigan, for instance, which is the state in the middle, it usually exhibits the highest average cost for people who pay by cash. around $4,300, which is nearly 3 times as high, nearly 3 times higher than Texas. So this shows that different regions can have different cost variation. Also, you can see that Florida has the greatest price variability amongst cash pairs. So you can see that if you're paying by cash, especially in Florida, then you'd probably be it's more likely to have inconsistent billing practices across hospitals, especially in Florida. We also noticed that the other pair category, which is most frequent in Michigan and Texas, was mostly associated with lower average prices, but this could possibly be due to discounts or low cost plans. The price pair interactions, for instance, like Aetna and Humana, this also significantly affected the predicted costs, which I think is kind of obvious, right? Like your healthcare provider also determines how much cost you end up paying. So this actually underscores the significance of, insurer-specific pricing dynamics. So the hyperparameters that we use for each model are described below. So we have linear regression where we didn't really tune any hyperparameters, but we obviously used ordinary least squares as a baseline model. And then for quadratic regression, which is just linear regression with a degree of 2, this obviously helped us capture the nonlinearities and the interactions as mentioned before. It performed way better than linear regression. And then for decision trees, our maximum depth was set at 6 so that we can balance both accuracy and interpretability, as well as to prevent overfitting. And then for the feed-forward neural networks, we used dense layers with ReLU, as well as 30% dropout so as to reduce overfitting. We also used like an Adam optimizer, 100 epochs, but we also stopped early so as to ensure that we restore the best weights.
Right, and so we also have some challenges and limitations in our model. When it comes to the decision making, we see a strong rise skew in price data, which did require log transformation to stabilize the variance and improve the model fit, but this makes it less accurate. This means that our linear regression and neural networks were trained on log transformed prices. And it did show that our decisions tree performed well in real prices because they were naturally designed to handle nonlinear relationships. But we do believe that we strongly overfitted our model, which will limit the generalization. We grouped rare pairs into an other category, which also simplified our modeling and reduced some noise. We do see that our neural networks architecture and dropout layers effectively reduce overfitting, though. In terms of some impact of our limitations, again, our price data includes extreme outliers, and there are values that reach up to 1 million, which can complicate our model training and our interpretation. And the decision trees' near perfect accuracy did indicate memorization rather than generalization, which once again reduces the real world applicability. We do see that while neural networks perform better at generalizing, they still underpredicted very high procedure costs and only perform well on log prices, not evaluating real prices. And so we conclude that our neural network achieved the strongest generalization with an R squared of around 0.87 compared to our linear and our quadratic models. And we do conclude that our decision trees showed significant overfitting despite near perfect accuracy. We did observe significant geographic and insurer-driven cost disparities, mainly in Michigan, which exhibited the highest average gas prices. Florida did show the greatest variability, and the other pay category consistently had lower prices. We do find that this model and our findings demonstrate the feasibility and the value of machine learning to uncover nuanced pricing behaviors. Some of our future directions include expanding our model to cover multiple medical procedures beyond subcutaneous tissue debridement, and also the possibility of multiple medical procedures being done at once, given that we know hospitals oftentimes group different codes, and that's something that our model is not trained to predict. We want to incorporate more advanced machine learning methods, such as ensemble models, random forest, gradient, boosted trees, and hyperparameters to tune to improve the predictive accuracy and reduce overfitting. We want to integrate artificial intelligence tools for auditing, as well as to ensure equitable predictions across diverse patient and payer groups. And lastly, multitasking learning approaches. These are some of our references, and we would like to thank everybody, including James, for his support. Thank you.
Thank you.
Thank you. Thank you.